Yeah, I've got one for Dr. O'Keefe. What would you say for the fellows that are training currently? Uh, what advice would you give them, knowing what you know now, so that maybe they can get a little ahead of the curve and perhaps be better prepared when they graduate?
I think that's a great question. Uh, First of all, I would encourage every fellow to go to one of the AtriCure Maze courses that are available, and to get as much experience, double scrub, triple scrub, stand on the table for any time that a Maze procedure is being done at your institution, even if you're not going to be the primary operator, to be able to get as much exposure and comfort with the anatomy. But at the end of the day, there may not be that many cases that are done where you're going to be confident and comfortable. So I think be a safe surgeon otherwise, and then find a practice where they're able to mentor you in this aspect of your practice.
Can I ask a question, Dr. O'Keefe? Do you think that if we make atrial fibrillation treatment a quality measure, just like the IMA, in other words, if the SDS or other societies measure how we treat these patients, do you think that it would be the adoption of treating atrial fibrillation would be much increased?
I think it would be. I think if there's that expectation as a society that we treat patients with AFib, I think you'll see more adaptation of it. But I think the other thing that's important is that we have the same language and we standardize what we're doing as surgeons, because what one of us calls a maze may not be a maze to someone else. And so standardizing that lesion set, that's really important. And that was critical and key in our group, so that our cardiologists know whatever surgeon is operating on that patient, they're going to get the same lesion set and hopefully the same quality.
I think that's very important to emphasize, that is standardization of lesion sets, so that a maze is a maze is a maze, whereas we all know that a maze is not necessarily a maze in everyone else's eyes. So in our group, no one, no matter how little AFib they get, just gets a PVI and a clip. We all feel that's substandard. And that at least everyone gets a left-sided box lesion with pulmonary veins and a left atrial appendage line, as well as a right-sided lesion in all cases, even for paroxysmal or new onset atrial fibrillation. For patients that even, for example, come in with acute coronary syndrome or non-STEMI and have an episode of atrial fibrillation not previously diagnosed, they will even get a full left-sided maze and right-sided lesions as well. So I think it's really important to standardize lesion sets, because without doing that, it's kind of a perpetual cycle that if you don't do an operation, you're not going to have good results. If you're not going to have good results, the cardiologists aren't going to think it works, and then it's a downward spiral. So in our program, it is very important that lesion sets are standard, and we all think that the more you ablate, the more lesions you do, the better results you get.